So thank you very much, Mrs. Chairman, and thank you to Professor Cittadini for inviting me back to this lovely island of Sicily. This is my first time in Palermo. I had the enjoyment of being invited to the meeting in Ragusa Ibla 2 years ago, and it's always a pleasure being here. Sometimes when I sit with a patient, she says, I need you, doctor, to guarantee that I can have a baby after chemotherapy. And of course, I have to tell her that I'm sorry, but I cannot guarantee you that. When it comes to fertility preservation, when it comes to ovarian tissue cryopreservation and embryo transfer as a means of fertility preservation, the pregnancy rates are around about 30%. So definitely there is room for improvement. Now, I must confess, I do not have the key to how to improve the results. If I did, I would be very famous and also very wealthy, and I'm neither. But there is definitely room for improvement, and I'm going to go through some of the various stages of fertility preservation with you to just highlight what can we do and how can we maybe optimize what we choose on behalf of our patients in each individual case. Now, when it comes to ovarian tissue cryopreservation, what things do we need to consider? Well, first of all, select your patients carefully. So there's no question that if you want high results, if you want good clinical outcome, you should only offer fertility preservation to the young women with a high AMH. Now, we all know that that is not life, and it shouldn't be either. A lot of our patients are in their mid to late 30s, even in their early 40s. But there's no question that you get better results the younger the patient and the higher her ovarian reserve is. Another thing you can maybe persuade the oncologist to do is to select the treatment protocol that has the least gonadotoxic effect. Now, of course, first and foremost, it's important that the patient survives and that she doesn't have any risk regarding treatment protocols. But in certain cases, sometimes, you can choose a protocol which will have as good a chance of curing her, but which will be less gonadotoxic. Before taking out the ovary and cryopreserving it, there are certain studies that have looked at, well, if you treat the ovarian tissue with either gonadotropin-releasing hormone agonist or with AMH, it may improve follicle survival after grafting, and these have been animal studies. Then comes the question of tissue collection. How much to collect? Now, this is, I think, various centers that offer ovarian tissue cryopreservation, they have a certain mindset as to either or. So they either take out biopsies or they take out whole ovaries, which we do in Denmark. You can say that I think that if there is a low risk of POI with the treatment protocol the patient is about to receive, maybe you should just take out biopsies so that she keeps as much ovarian tissue in situ, which will give her a higher chance of a spontaneous pregnancy. But if there's a high risk of POI, why not take out the whole ovary? Because she has a very high risk of not retaining her ovarian function after treatment. And the more tissue you have in the freezer, the better chances you can give her afterwards. Then you can you have to treat the tissue with cryoprotectants before freezing, and there are various cryoprotectants you can use. The majority of the cases of ovarian tissue cryopreservation has been after the slow freezing protocol, and also the vast majority of the children that have been born have been as a result of the slow freezing protocol. But it's also possible to vitrify ovarian tissue, and I think a couple of births have been published after vitrification. So, what is the ideal transplantation site? I think that after we've been hearing all the talks today, that there's no question that you give the patient the highest chance if you transplant the tissue orthotopically. And orthotopically simply just means that you put the tissue back to where it belongs, be it in the remaining ovary or be it at the site of the removed ovary in a little peritoneal pocket. There are also different ways of transplanting the tissue, as we have learned. So you can choose, as they do in Belgium, to strip the cortex from the remaining ovary and then put the ovarian tissue on top of that. Or you can create subcortical pockets underneath the surface of the ovary and then put the tissue there. You can also put the tissue in little peritoneal pockets close to the tube so that, at least in theory, the patient can get spontaneously pregnant. If you put the tissue back heterotopically, you can either do it in the arm, the forearm, which has been described, or in the abdomen or the abdominal wall. Of course, the patient needs IVF in order to get pregnant then. Different operative techniques have been used and are used, so you can use a laparotomy, you can use laparoscopy, you can combine them too with a laparoscopically assisted mini laparotomy. You can do the procedure as a two-step procedure. Now the purpose of this is that you promote angiogenesis, so the patient comes in, has a first laparoscopy in which you scratch the surface of the ovary or the peritoneum in order to enhance neovascularization, and then 1 week later the patient comes back for another second laparoscopy, and then you put the tissue back in a nicely vascularized area. And you can also do this robotically assisted. Of course, the question is then how much tissue to transplant and how big of a piece of tissue do you want to transplant. We just heard that in Spain they transplant 50% of the tissue. That's the same as we do in Denmark. Then the patient has enough tissue for 2 operations. You can transplant cortical strips or fragments of about 5 to 1 millimeter in thickness. This is the standard size of the cortical strips. You can transplant even smaller pieces, as in the microorgan ovary, which has also been described. The whole ovary transplantation has been studied in animals. It's proven technically quite difficult to have good results from that. And then, of course, comes the question, what about after transplantation? Should you let the woman go home and try for and hope for a spontaneous pregnancy, or should you be more active and immediately go for IVF? Now, these patients are not different to any other fertility patients you have. So a lot of them will have other factors like blocked tubes, or they might have a husband with a low sperm quality, which would then indicate that maybe they should be offered IVF. Remember, when you put the tissue back, always test the patency of the tube, because you don't want a blocked tube and then send her home to try for a spontaneous pregnancy. So these are all various things you need to consider. Now, one of the biggest challenges we're faced with is the follicle loss that is seen after cryopreservation transplantation, most likely caused by ischemia and slow revascularization. Now, several studies have looked at various factors which could increase the vascularization process, reduce the ischemic period, and thus hopefully have a better follicle survival in the transplanted tissue. And there are certain angiopoietic factors, such as angiopoietin 2, which has been found to increase the intact follicle ratio and the number of blood vessels in mouse ovarian tissue grafts. Vascular endothelial growth factor and fibroblast growth factor 2 has been found to promote revascularization and survival rate of follicles also in mice. Even AMH has been studied. There's one study which found that there was a decreased follicle apoptosis rate in mouse ovarian tissue vitrified and warmed in media containing AMH. But of course, we still need more studies on this topic. So let's move on to IVF. Can we do anything to improve the results from IVF? Again, patient selection. Maybe the older patient above 35 is better off being offered oocyte donation. Treatment protocol. What about the IVF protocol? Is there any hormone that is preferable? In my opinion, no. You can give recombinant FSH, you can give HMG. I think if you have in most cases, it's preferable to offer her the short antagonist protocol simply due to a time issue. We don't have time to do the long agonist protocol, and why should we? Sometimes if you have time, you can even do a dual stimulation where a couple of days after oocyte pickup, you start another stimulation. You can start the patient randomly. Any time of the cycle when she presents herself to you, you can start the ovarian stimulation. And this is based on a lot of the pioneering work by Michael von Wolf. If you have a breast cancer patient, be sure to add letrozole or tamoxifen to the stimulation protocol. I think that all patients, unless there are contraindications against it, should be offered a gonadotropin-releasing hormone agonist for ovulation induction in order to prevent OHSS, which would possibly postpone her chemotherapy, and you don't want to do that. If you have a lab which is comfortable with vitrifying oocytes and which has good results, then I think that is preferable. A lot of our patients are young and they don't have a partner yet, or they're not yet in a stable relationship. We know that the divorce rate, at least in this part of the world, is quite high. And why risk that you can't use your cryopreserved embryos because you've divorced your husband? You can choose to freeze oocytes on day 2 to 3, embryos on day 2 to 3, or go to the blastocyst stage. You can fertilize oocytes with donor sperm if the patient doesn't have a partner, or with her own partner. And then what when the woman comes back for her to use her frozen embryos? Most of them, of course, will be menopausal, so they need a stimulated cycle, but if they still have a cycle, you can always offer them an unstimulated cycle. And there are no differences in the outcome. And of course, the luteal phase support is important. You all have your own way of giving luteal support in the different clinics. I acknowledge that, as long as you bear it in mind and give it to the patient. Now, what I haven't mentioned here is that if you have time, it's a good idea to combine ovarian tissue cryopreservation with IVF, if you have time, because then she has a bigger chance of a positive result after chemotherapy. So this was the first part of my talk. The next part of my talk is spontaneous pregnancies in patients following ovarian tissue recovery. Now, a lot of our patients do keep some of their own ovarian function after chemotherapy, and a lot of them will not need their ovarian tissue or their oocytes in the freezer. In fact, I think the majority of them do. So we asked ourselves, now this, I have to say, this beautiful painting by Tizian. I took a picture of it a couple of weeks ago where my youngest son and I went to Firenze, and we went to the Uffizi Gallery, and I thought this is a wonderful painting, and this should definitely illustrate this part of my talk. Now, she's got a round belly. I don't think it's because she's pregnant, but this was the ideal woman at the time with a bit of curves. I want to give you a case of a typical patient who is referred to you for fertility preservation. This woman was 32 years of age in 2013 when she was diagnosed with stage 2 ductal carcinoma of the breast, ER positive, HER2 negative. Now, this woman had just stopped on her oral contraception due to a pregnancy wish when she fell ill. She was referred to me. I scanned her and found a nice ovarian reserve, an antral follicle count of 29. Now, she was very keen on having a baby, so she asked if she could have both ovarian tissue cryopreservation and IVF, and she did. So first she had her right-sided mastectomy, and then she had her right ovary removed for cryopreservation. And then she came back, and I stimulated her, got 8 oocytes, and 4 embryos in the freezer, and it has to be in that order. So you have to take out the ovary first and then do the IVF on the remaining ovary, not the other way around. She had standard chemotherapy, 3 series of CE, 3 series of docetaxel, followed by tamoxifen, recommendation 10 years. Almost a year after end of treatment, she came back because she was anxious. She wanted to know, how do my ovaries look? How does my ovary look? She only had 1. Will I be able to have a child? She said that her periods had returned 7 months after the last chemotherapy, and this is very typical. They were regular. I scanned her, and she had a nice AFC of 10 in her remaining ovary, AMH of 5.5 picomole per liter. She was still on tamoxifen, so I sent her back. She came back crying 3 months later because she was so nervous. She wanted to know if there was still a chance. So I did another AMH, and unfortunately, it was now then below the detection limit. This was the old Beckman-Coulter assay where the lowest detection limit was 3. Now we've got Alexis from Roche where it's much more sensitive. So she was quite distraught. She was still on tamoxifen. She came back 1 year later. She had stopped with tamoxifen. She wanted to become pregnant. She had an IUD, which I removed. I did another AMH test, which at the time was 4 picomole per liter. So she went home, and the next ovulation she had, she became pregnant spontaneously. And in October 2016, she gave birth to a healthy baby girl. She breastfed for 6 months, came back, wanted another baby. Now, her AMH was now 8.7, so it had increased. We thought, okay, let's go for the embryos in the freezer because the oncologists were getting a bit impatient. They wanted her to get back on tamoxifen. So we did 2 frozen embryo replacement cycles. She didn't get pregnant. She went back to her oncologist and begged if she could please have another try for a baby, and then they were persuaded. So she came back and persuaded me to do 1 IVF cycle. So I gave her Lonva, got 11 oocytes, all fertilized and cleaved. She was transferred with 2 nice 4-cell day 2 embryos. The remaining were cultured to the blastocyst stage. 1 was frozen, and after 2 weeks she had a positive HCG. Week 7, confirmed a twin pregnancy. Week 9, one of the twins had died, but she's now very close to the 3rd trimester, and both mother and baby are well, and these are the lovely flowers I got for Christmas from her. So she is an example of a patient who may not have needed either ovarian tissue cryopreservation or IVF, but you don't know. You don't know when you have the patient. Now, she is in this intermediate group. Now, of course, when you have patients in the high-risk group, more than 80% risk of POI, I mean, there's no doubt they should be offered fertility preservation. And also, when you have the patients in the low-risk group with a very low to non-existing risk of POI, as is seen in, for instance, patients who receive ABVD for Hodgkin, or patients receiving non-alkylating agents, well, they probably shouldn't be offered in. But it's in this group, the intermediate group. That's a tricky group. Now, she is here and probably would have a 40 to 60% risk of POI, but she didn't get POI. Good for her. We asked ourselves the question way back, because we started offering ovarian tissue cryopreservation in 1999. And we now have more than 1,000 ovaries in the freezer in Denmark. Now, in 2013, we asked ourselves, do we offer this to too many patients? Because we didn't have a lot of patients coming back for requesting autotransplantation. So we decided to do a questionnaire where we would ask the patients about their fertility after chemotherapy. We wanted the patients to be adults, so we excluded the children, and we wanted a certain follow-up time period, so more than 2 years after cryopreservation of the tissue. They should have undergone a gonadotoxic treatment. At the time, we had 410 women with ovaries in the freezer. 191 of them fulfilled the inclusion criteria. They were sent a questionnaire. 6 of them we couldn't find the address, 3 had emigrated, 182 were sent the questionnaire, 33 didn't want to participate, but we had a response rate of 78%. 6 were excluded because of bilateral oophorectomy, 143 patients were included in the study. Now these are the diagnoses, the age, the number of the patient. The majority of the patients had suffered from either breast cancer or lymphoma. The oldest patients were the breast cancer patients, and the youngest patients were the sarcoma patients. They had all received chemotherapy. 20 had received bone marrow transplantation, and 4 either abdominal radiation or spinal radiation. We had a long follow-up time, a mean follow-up time of 58 months, with a range between 24 and 129. So this was a questionnaire. I didn't see the patients. So the only indicator of POI was amenorrhea. What we found, not surprisingly, that all the leukemia patients reported amenorrhea. And this is not surprising. They had all received bone marrow transplantation. The breast cancer patients, on the other hand, and that surprised us a bit. The majority of them still had cycles, spontaneous cycles. Also for the autoimmune patients, it's only 7, but they all had their cycles as well. We asked them how many pregnancies had there been before cryopreservation, and 35% of the women had been pregnant before treatment. After treatment, 57 of the 143 women had a pregnancy wish, and 72% of these had succeeded in becoming pregnant, giving birth to a total of 50 children. There was an additional 7 unwanted pregnancies and 7 women without a pregnancy wish. Okay, so it looked pretty good. So we thought, well, did they need help to become pregnant? They didn't. So the vast majority of them became pregnant spontaneously. 2 of them needed IUI, 1 needed IVF, 2 had egg donation, and 1 didn't state how she got pregnant. We asked them, how long did it take for you to get pregnant? And again, we were quite surprised that 69% of them got pregnant either immediately or within the first 3 months of trying. So these are women, you have to bear in mind, who had received chemotherapy. They only had 1 ovary because we had removed the other one and frozen it. And yet it still looked as if their fertility was pretty good. What about the fate of the 73 pregnancies? Well, at the time, there were 45 live births, 5 were ongoing, and they have now delivered, of course. There were 15 spontaneous abortions, 7 induced abortions, and 1 ectopic pregnancy. So we also asked, I don't have a slide about this, we also asked the women, how long, did you deliver at term or did you deliver prematurely? Were there any complications? They all delivered at term. The birth weight of the child was normal. So we were quite reassured by the results of this study. I don't think I'll go through this due to time issues. 2 minutes left, yeah. So we got time for the conclusion. Spontaneous recovery of ovarian function after chemotherapy is not uncommon, and pregnancies do occur. And I want you to have this as a take-home message when you see your patients, that it's not all black and white. There is hope. There are women who are capable of getting pregnant by themselves, on their own, after chemotherapy, and they don't need our help. I think it's important to give this message to the patients because it gives them hope. No question about it, we still need studies in order to optimize fertility preservation. We need further studies to improve follicle survival after transplantation, and one of the things we've heard today and learned today is the new exciting results regarding stem cell transplantation. So I think that is one of the future research areas which will bring a lot of interest and hope. So thank you for your attention.